Hello everyone, I am Arvind Kaur, Assistant Professor Anesthesia, MMI MSR Mulana. Today's video is how we secured a 3.5 French central venous catheter in a 2-month-old baby who reported to pediatric emergency in status epilepticus. The baby had no peripheral venous access. We, seeing this situation as an emergency one, rushed through the procedure in the pediatric ICU and were not able to meet all the criteria of sterility. And we are very sorry for that. We managed to give our best with the bare minimum equipment available, and another challenge that we faced was that the baby was neither sedated nor paralyzed and was moving constantly. So we decided on going USG guided. You can see that we first tried to anatomically locate the internal jugular vein by palpating the carotid artery, as the vein lies lateral to the artery. We are doing it at the level of the cricoid. The USG probe that we used was a linear one and it was washed with sterilium 3 times. After we visualized the vein using the USG probe, as you can see in the video, we keep the vein at the center of the probe and we puncture. After puncturing the site, we withdraw a bit because it has been seen that by puncturing the vein gets compressed, and after withdrawing we usually, when we puncture, the vein gets compressed, we cross the vein, but after we withdraw a bit we get into the lumen of the vein as is seen, and we get a flash of blood. We try to stabilize the needle as the vein in such a small baby is of very less caliber and the needle moves by millimeter. After we get a good flow of blood, we stabilize the needle by resting our hand at the face of the baby and we try to put in the guide wire. The guide wire is put in to the desired length and we keep on checking for arrhythmias. Once arrhythmias appear, we stop then and there. After securing the guide wire, we remove the needle very slowly and cautiously. And railroad the internal jugular catheter. Here we are dilating the site of entry using a dilator. Now we'll railroad the central venous catheter. This is the Seldinger's technique that we are using. Once we get a hold of the guide wire at the end of the port, we put in the catheter and the catheter is put till 5 centimeters length. Now the guide wire will be withdrawn. And we are flushing the port. After flushing all the 3 ports, we are doing a bedside test that we have learned from our experience and from our teaching days. We attach a IV line to one of the ports, usually the distal port, and check for the flow of fluid. This we have learned from our learning days that if the fluid goes in freely, we are in the vein. Though I repeat again, it is not a confirmatory test, but if we are in the artery, since the pressure in the artery is high, the blood will start going up in the IV tubings. In this, when we connected the IV tubing to the port, you can see that there is free flow of fluid going into the line. We fix the line using sutures in place. Putting on sutures on a crying baby was very difficult since I'm a mother myself, but then this is the life of a doctor. We put on a sterile dressing. And call for X-ray, because then X-ray is the one that is going to confirm the position of our line. This is my team, my postgraduates, Praveena, Sandhya, my third year PGs. This is the X-ray of the baby after the insertion of the line, and you can see the position of the line. Thank you guys.